Recording. Welcome everybody to our weekly lecture series. This week we are opting to do it on Wednesday instead of Saturday so that more of you could join and also enjoy the nice weather outside on Saturday if you wanted to. Today we have a great panel of experts joining us. And one of our own, Dr. Carol Yanow, who is at Cornell, sort of cued me in about this great lecture series, not great panel that happened at Cornell. And so I'm going to invite Carol to introduce the esteemed panel, and we'll get started soon. If you have any questions, you can use the chat function to send the questions to me. Those of you who have listened to the part 1 of the same topic from the same speakers and have questions sent out to me already, I'm going to take your names and ask those questions on your behalf if you are not on the call. But if you are on the call, when it comes time to ask questions, please unmute yourself and ask the question. And I'll clarify it again once the question answers part starts. Okay, over to you, Carol.
Some of you may remember the impact that this Grand Rounds had on my work on the support line. At a debriefing session in May, I presented a caller who was lucky enough to call and catch me the day after I had heard this Grand Rounds at Cornell. Her chief complaint was, quote, massive survivor guilt, unquote. And I was able to help her even in that one session by using this framework of moral injury and the roadmap that this panel provided me just the day before, where it was fresh in my mind. So I'm so happy that they agreed to come share it directly with all of you. Dr. Sonya Norman is a clinical psychologist and professor of psychiatry at UC San Diego School of Medicine. She is director of the PTSD Consultation Program for the National Center for PTSD and conducts research on the treatment of PTSD and addictions and novel treatments to address trauma-related guilt, shame, and moral injury. Dr. Norman has over 120 publications related to PTSD and associated problems, and has grant funding through the VA, Department of Defense, NIH, and the Patient-Centered Outcomes Research Institute. She received her BA from Vassar College and her PhD from Stanford University. The other 3 panelists are affiliated with the Weill Cornell Medical College and the New York Presbyterian Hospital in New York City. Dr. Joseph Fins is the Davis Professor of Medical Ethics and Chief of the Division of Medical Ethics at Weill Cornell, where he is a professor of medicine and a professor of medicine in psychiatry. He also serves as the Director of Medical Ethics and an attending physician at New York Presbyterian, where he chairs the Hospital Ethics Committee. At Yale Law School, he is the Solomon Center Distinguished Scholar in Medicine, Bioethics, and the Law, and will be a visiting professor of law during the coming academic year. A past president of the American Society for Bioethics and Humanities, Dr. Fins serves on the New York State Task Force on Life and the Law, which authored the 2015 ventilator allocation guidelines for pandemic avian flu. During the spring of 2020, he directed our hospital's medical ethics response to the COVID-19 surge in New York City. Dr. Fins received his BA from Wesleyan and his MD from Cornell Medical College. Dr. Andrew McAlevey is an instructor of psychology and psychiatry at Weill Cornell Medical College and an assistant attending psychologist at York Presbyterian Hospital. He primarily works with trauma and PTSD treatment with military, medical, and other civilian traumas. During the hospital's response to the current pandemic, Dr. McAlevey served as primary liaison from the Department of Psychiatry to several departments and divisions in the hospital, including emergency medicine. Dr. Andrew Edelstein is an instructor in clinical psychiatry at Weill Cornell and associate attending in the Consult Liaison Psychiatry Service at New York Presbyterian Hospital. Prior to the pandemic, his academic interests included psycho-oncology and developing de-escalation strategies for medically compromised patients. During the initial COVID-19 surge, Dr. Edelstein continued to provide inpatient consultations for the management of delirium, premorbid severe mental illness, and suicidal behavior. In addition, he formed several liaison relationships with various services and departments throughout the hospital for emotional and mental health support. Let's please join me in welcoming the panel, and Dr. Norman will get us started.
Thank you so much. I was so happy to learn about your work and what you're doing, and it's really an honor to be presenting to you today. I'm going to start off with a couple of slides just to introduce the topic, and then actually turn it back to Drs. McElvey and Edelstein to give a couple of composite case vignettes to really bring these issues to life. Let's see. So just to quickly mention that I have a couple of disclosures of a book on this topic and a grant by the Department of Defense. So in terms of introducing this topic of moral injury, the idea here is that we all have values, whether we think about them or not, whether we're consciously aware of them or not, that really drive the choices we make, drive our behavior, and drive how we feel about what we do. So we may not think consciously about our values, but they really underlie everything. And when our values may come into sight is when they're actually violated. So something happens, maybe a traumatic event, maybe just a highly stressful event, certainly the kinds of situations healthcare workers have faced during COVID-19 that we'll get more into. And it's an event that where someone's values and morals are violated. Either they do something, they can't stop something, or they witness something that deeply violates these values that they may not even realize were so important to them. And in response, maybe someone feels okay, they kind of make sense of it, they move on, but maybe they feel moral distress. That might involve guilt or shame or a sense of betrayal by their leaders or the institution. And again, that might resolve over time as they kind of make sense of it. And we'll talk during the talk about some ways that peers can help each other resolve this kind of moral distress, or at least cope with it. And moral injury is when this moral distress really has lasting effects that might be psychological, they might be biological in terms of health, it might be spiritual in terms of someone changing their relationship with their spirituality, with their religion, behavioral or social. So today we'll really focus on kind of this moral distress and even this more severe moral injury, and what that looks like, and what it's related to in terms of these kinds of impacts. So I'll briefly stop there so that I can let my colleagues really bring this to life, and then we'll go on with the PowerPoint part of the presentation.
So I guess I'll just do a brief discussion of the context for the work that Andrew and I are going to present, which was more well known at Cornell, but I realized actually we should probably give some context for it. So what was originally called the Liaison Program and is now called COPE Weill Cornell was one of the many supports that our Department of Psychiatry set up for the healthcare workers at Weill Cornell and New York Presbyterian Hospital when the pandemic first started. The work that I think Andrew and I are both going to be talking about comes from originally what was focused as more teams-oriented support. So individual psychiatrists and psychologists were assigned divisions or departments to work closely with, but mostly in a group format, and then to identify individuals who may need additional individual services and funnel them into appropriate supports at that point. And so my work was with a few different departments, but as mentioned in the introduction, especially has been with the emergency medicine department. Those of you who watched the previous grand rounds heard about a case that I presented there that I will just sort of describe the brief parts of, the highlights now, and then talk for a moment about what types of treatment, one specific treatment intervention that was particularly helpful. So one of the individuals that I ended up working with both in a group and an individual format was someone who I called. Can you hear me? Okay. I got a message that I was muted. 43-year-old and married physician, works some telehealth and some in-person emergency medicine shifts. I'll go through this briefly because some of you may have already seen the video. At the beginning of the pandemic, his wife had to quit her job in order to provide full-time childcare as the schools closed. And that seemed more workable to them than the other options available that some of their colleagues participated in. But during the experience of the pandemic, his own anxiety I'll be at the hospital, particularly as an emergency medicine physician, feeling that nothing he was doing would make any difference, and that his training wasn't relevant to this situation because all he was able to say was just go home, and if it gets hard to breathe, then come back to us, and that they couldn't even provide tests, let alone a functional treatment. He did have several conflicts with administration over PPE, although he was singled out and praised for his hard work ethic and desire to be within physical proximity to patients, particularly early on in the pandemic, while other physicians felt that they needed more protection and distance. Overall, in the group meetings, he really described intense feelings of guilt throughout our conversations and highlighted for others in the groups how they had maybe been feeling guilt without realizing it. And specifically, he named several aspects of his guilt: guilty for leaving his wife with the kids, guilty for not being in the hospital when he was on telemedicine shifts, guilty reading about other hospitals where the outbreak was worse and the resources were more scarce, along with many other prompts for guilt. There were many displays of gratitude from the city, including daily clapping at 7 p.m. and displays of lights and trucks from the fire department, which he had a mixed experience with, both appreciating that these might be for him and his colleagues in some way, but also very much and predominantly feeling like he did not deserve this applause because there wasn't anything that he could do. Eventually, he and I had initiated a 4-session time-limited treatment, and I just wanted to give you a sense of how over time, one of the things that disturbed him most during this, he witnessed a neighbor of his who succumbed to a long chronic terminal illness die. The close neighbor he'd known for years, he just happened to be closely involved with the family. And he got to witness as this family who had kept this individual at home, brought in family members, brought them virtually, had a long period of time to say goodbye, were able to sort of provide what he described as a beautiful death. This struck him and really disturbed him based on all of his own experiences at the emergency department of essentially having to shuffle families out the door before they got a chance to say goodbye fully, giving them only a few minutes before they had to take the patients into the hospital, never knowing whether they would see their loved ones or not. And he was, I wouldn't say obsessed, but at least for many days was really perseverating on this discrepancy in how the death process could be or should be, in his words, and how he was routinely seeing it occur. In our brief sessions, I encouraged him to reflect on his desire to help, meaning to use this sort of sense of guilt and responsibility to identify his own pro-social desire, to identify his deep sympathy for the suffering of his patients as a strength in himself, and inquired about his sense of the appropriateness of the measures that the hospital was taking to protect him and his peers. Did he think they were appropriate or not? Overall, he ended up sort of through these conversations deciding that these measures felt necessary at the time, but also resolved to make some concrete actions and change. So he ensured that families in the future would have enough time and that he would go out of his way to inform them. and that he also went to his hospital administration to talk about the ways patients were being admitted and visitation was being managed later on. The take-home message that he took from this, and I learned this weeks later at another group meeting, because he had written this down and kept it next to his bedside apparently, was that he went from thinking about these as should thoughts, and though I'm a cognitive behavioral therapist, I didn't really hammer that home for him, but he went from taking these should thoughts into instead saying, not what should or should not happen, but what do I want and what can I do right now? And that he sort of took that and internalized it in a number of ways, and wanted to share this with his peers in the coming weeks as his major way of working through this. And I don't know if Andrew wants to go next.
Thanks. Yeah, I just wanted to speak a little extemporaneously. We were discussing last night just how much of a paradigm shift this was for me to be able to listen to Dr. Norman and also be able to work with Dr. McAlevey and Dr. Joan DeFridi at Cornell. We just going over this case, and I'll try to do a similar sort of review, but not get too deep into it to avoid redundancy. But going over this case again, I was reminded that we have kind of all these very vacuous, we call garbage bag diagnoses, like adjustment disorder, acute stress disorder. I mean, acute just maybe focusing more on the adjustment disorder, because I don't think we've ever seen like a paper or review of adjustment treatment for adjustment disorder that blew us away. But that's often what we reach towards when we don't have the framework to work with. And now having this framework has been so invaluable, not just in clinical work and helping out other clinicians and hospital workers, but looking around the world. And it's hard to look at a protest and look at the NYPD and look at the protesters' experience without bringing in this moral injury framework. And so this, I really believe this is like a seismic shift, at least for me, where it's equivalent to, the removal of hysteria as like a major diagnostic tool. So I kind of try to be brief. This was a composite case of about 3 nursing leaders I worked with over the course of the initial surge. And it was broken up into 3 phases. So there's that initial phase, which was, just to be succinct, felt like moving furniture on the deck of the Titanic. The sense that we really had no idea what was coming our way. There's just this flurry of activity. And this leader was in this position of giving orders that they really didn't necessarily believe in or buy into, asking staff to come in without the right PPE or without a sense of security, and this deep sense of betrayal of the people that they were betraying the people that were depending on them to keep them safe, and it fueled a sense of doubt, self-doubt. As the surge came, there was this renewed sense of confidence and agency that, especially with the critical care unit and the COVID designated units, but that was starting to take its toll. The beds just dramatically filled with ventilated patients. And now this nursing manager was going home and just feeling profoundly alienated from their family. They've discussed a little bit some of the irritability, the sleeplessness, the difficulty just switching roles, and leading to this angry outbursts against their adult child who had returned home and became apoplectic over like the fact that they didn't clean themselves sufficiently. And it's so exhausted they can't even bring themselves even to apologize, but this being terrified of this other side of them that just is so, not just feeling alienated from the world around them, but themselves, this new person. And then entering into this sort of this denouement, this phase where now we see these patients for weeks on end in the ventilator, the drama, the acuteness has dissipated a little bit, but you're left with these patients who are profoundly debilitated, many of them trached, profoundly delirious, and just doing the math and realizing how that you're just going to be left with tons of patients without without technicians at bedside who could provide one-to-one, and this ultimately this dehumanizing effect that has, and this conflict it has with their identity as a nurse, as a caring person, that now there's this hard to draw upon the well of empathy and to see them or to see the work as something gratifying, which yeah, it's hard. They're having a hard time finding meaning and substance to their work. So just want to hone in on like the sense of betrayal that they're experiencing themselves with their, both towards their own superiors, but also those under that they feel responsible for. The transgressing their personal values, putting their staff at risk, feeling alienated, witnessing patients suffer, this deep sense of isolation, but unable or just unwilling to intervene. So with that in mind, and if you would, hopefully, maybe we could also revisit the cases afterwards, after Dr. Norman gives her wonderful talk.
Thank you so much. And I think I'll return to both of these examples as I give the talk, because they're so rich and have so many aspects of moral injury covered. So let me share the slides one more time. And I'll move on from here. So I mentioned that moral injury is this violation of values occurs, and the most common reactions that we think about as part of moral injury are guilt and shame, and sometimes a sense of betrayal if it was really witnessing or being part of sort of what's perceived as bad leadership or institutional decisions. So I'm going to talk about guilt and shame a lot. So I just wanted to take a minute to talk about what I mean when I use these terms, because in the literature, they're kind of used in a lot of different ways. So the way I'm going to be talking about them is guilt is remorse about an action. I did something bad and I feel bad about it. Whereas shame is when that bad feeling kind of becomes a global attribution. I am bad because of what I did. In my work with veterans who have moral injury and guilt and shame, from war experiences, we almost always see the shame. It's that I'm unlovable because of what I did. If people knew what I did, they wouldn't want anything to do with me. It's really become more global, not just I feel remorse about an action, but this kind of more, I am broken, I am flawed because of what happened. So let's start by thinking about the kinds of events that might cause moral injury. We call these PMIEs, potentially morally injurious events. So broadly, it could be making decisions that affect the survival of others, decisions where all options will lead to a negative outcome. Although what I find is when people first come to me, they don't realize that all options would have led to a bad outcome. They're just assuming the option they chose led to a bad outcome. And there could have been a very good outcome had they just done something else. But, as COVID-19 clearly shows us, that's not always true. They went against their values by not doing something. So an act of commission. They froze, they could have helped someone, but they didn't. They could have switched shifts with someone, but they didn't, and something bad happened. Let's see, and witnessing or learning about such an act. So my work started in combat about over a decade ago now. I started one of the first PTSD treatment programs at the San Diego VA for veterans specifically who had served in Iraq and Afghanistan, because we had such a large population coming back to San Diego. And I was very proud of developing an evidence-based program where people were getting best practice treatments. But especially at that time, our PTSD treatments really spoke more to fear and anxiety than around this kind of suffering that comes from I did something and now I have to live with it, or I froze and I didn't do something. So, my staff were coming to me telling me that what they were, their language in these treatments didn't quite fit what patients were presenting with. And we started collecting data on it, and we started collecting data on what kinds of situations were causing people to feel guilt and remorse. We'd all heard about survival guilt. We all assume that someone who's not a killer might feel bad for, killing someone. But really, we realized it was much more complex and nuanced than that. So for example, someone might feel okay about killing in the line of duty because they knew that might happen when they went to war, and that, they knew that was what they signed up for. But at the moment that they killed, they felt exhilaration. They liked it, or they felt nothing. And what does that say about them? So maybe that was the moral injury rather than the act itself. People would freeze, or they'd have been up for 3 days and fall asleep on patrol and something bad would happen. They would witness an act, and maybe they could have stopped it, but what if they had stopped this crime they saw in progress, they would have then put everyone else in their unit at risk because they would have exposed their, location. And so they had to make this decision where they stopped someone from getting hurt or put the lives of many people they knew and cared about at risk. And so whatever choice they made, they would feel bad. And sometimes it was someone sitting in an office making decisions, but those decisions affected the survival of others. And so even though they weren't in the war zone, they didn't see what happened, they knew what happened, and they had to live with that. So I think the big lesson from that was just how varied and how unpredictable these situations were, and how in the same situation people could make one choice or another choice, and either could lead to these negative, to this pain and moral injury, because there was no good situation. So now we're in this global pandemic, and we have these healthcare settings where there's a surge, and maybe there's inadequate tools and resources. Maybe people are being thrown into situations, they're a generalist, or they're a hospitalist, and suddenly they're, supposed to function like a pulmonologist. So we're starting to study what might, or think about even, I would say think about what could cause moral injury here. So certainly that's one scenario, is this inadequate tool, resources. But as much as healthcare professionals sign up knowing, for their profession, knowing that they're going to see suffering and death, we don't anticipate this scale, right? That some of us have seen through the pandemic. So that can certainly be a source. When honoring one set of values might feel like failing in another. And in one of the examples, it was, the nurse chose to go to work and do what they were trained to do. But then they would come home, and it would cause their child all this anxiety that they were going to get sick. And so, do they appease their child? Do they do the work? Kind of these, again, what could feel like an impossible situation. Feeling like your own life is at risk while you're trying to save someone else's. What kind of decisions do you have to make when your own life feels in danger? Witnessing or participating in rituals around dying that might go against your own values, like having to witness patients dying alone, separated from their families. And again, the supervisors who are sitting in an office, maybe they're not on the floor, they're not with the ventilated patients, but they might be deciding what providers they're sending into those units where, where the providers might get sick. And so they're making decisions that might, or who gets the ventilator, and they have to live with those decisions. And we've also heard again that sometimes, when you're on these units and there's patient after patient that's ventilated, you could feel numb or nothing after a while, just like we hear from, some of the veterans during combat. And again, what does that say about me? What does it say that I was with all these lives at risk, all these humans, and I felt nothing? And then, abiding by policies which go against one's values can certainly be another source. So that's just laying the stage of some of the potential situations. That is certainly not a comprehensive list. I don't think we'll ever have a comprehensive list, but I think that gives you sort of a flavor of some of the categories that we're thinking about. So having said that, I think I'm sure I'm speaking to the choir in regards to resilience, and that most people who experience these kinds of situations, they'll be okay, right? Most healthcare workers won't experience lasting distress. They, again, go into the profession with expectations around seeing suffering and death. Their training prepares them. Healthcare cultural norms, support of each other, support of peers and leaders, having access to peer support like your organization, hopefully getting acceptance and from family and culture at large. Although, as we heard in the example, sometimes when you're feeling this moral injury, that support can actually feel like an affront when you don't feel like you deserve those kudos or that support. And some we may discover have positive growth, that they come out of these kinds of experiences really with new direction, new meaning and purpose. And some will have moral injury. And so again, some of the common reactions in addition to guilt and shame are anger and disgust, maybe betrayal. Some of the behaviors we see linked to moral injury could be self-sabotaging. This could be from that sense of, I don't deserve to feel better. I don't deserve to feel happy. I see this a lot in treatment because these patients are sort of half in, half out. And we might say they're not that motivated, or, But what I see sometimes is a real struggle between part of them wants to get better and part of them doesn't think they deserve to get better. And I see that ambivalence is, I think, that struggle playing out. There's this sense of being damaged or flawed permanently because of what they did or what they lived through. We see changes in sleep and behaviors, more isolation, avoidance. And we could see sort of, I mean, this has some overlap with burnout in terms of that loss of compassion. Empathy could be common. And then in more severe cases, what we see is, when we look at studies of moral injury, and most of this research has been with service members and veterans at this point, and it's my goal to change that. And I think there's many of us who are interested in moving this concept forward. But what we see is it's actually hard to study moral injury outside of the context of PTSD. Most people seem to have both. I think with COVID-19, that might be different, actually, that there will be more situations that may be where there isn't PTSD, but there is this other kind of suffering. But what we see is even among people with PTSD, if they have moral injury, they're more likely to have suicidal thoughts and behavior. They're likely to have more severe depression, more substance use, worse functioning. And then I do want to spend a little time on PTSD because it's very overlapping. And there's been, I'd say, a lot of controversy since this concept of moral injury really kind of got popular in this veteran space around 10 years ago, around whether it's something unique outside of PTSD or whether it's pretty overlapping with PTSD. So in my research studies, we look for people who have guilt and shame from a traumatic event, but we don't require that they have PTSD. It's not an inclusion criteria for the study, and yet almost everyone has met criteria for PTSD. And if not, they've been short a symptom or two. They're not completely asymptomatic for PTSD. And most of the events that people bring to us are criterion A traumatic events, so life-threatening. But sometimes we'll hear about situations that aren't, and I think, again, we'll maybe see more of that with COVID. But a morally distressing event at its base doesn't have to be life-threatening, but it does have to transgress someone's understanding of morality. There has to be this violation, whereas a criterion A usually is a life-threatening event. And then there are some distinct distinctions, and I think more than anything with moral distress, there's more of a focus than on PTSD on sort of the spiritual and existential kind of part of having had this experience. Often that is part of PTSD, but we don't focus on it in the diagnosis. We don't focus on it in the symptoms in terms of this existential crisis and spiritual crisis it might throw someone into. And certainly avoidance is a core symptom of PTSD, but when we think about avoidance in PTSD, it's more about not wanting to think about the trauma. It's too distressing to me, so I don't want to think about it. Whereas with moral injury, we might think about it more as I want to protect you from me. I'm avoiding you because you deserve better than me. There's the sense of not deserving to get better. And some people think of moral injury as maybe where PTSD was, 30, 40 years ago. We kind of knew it was out there, but we weren't sure what it was yet. There hadn't been a lot of studies, so maybe that's where we are. Having said that, there's a lot more overlap than differences. They both have this reminders of the trauma are part of it or the event, increased suicide risk, intrusive thoughts, sleep problems, substance use, the self-sabotage, negative cognitions, guilt and shame as of 2013 in DSM-5 are symptoms of PTSD, anger, disgust. Betrayal can certainly be part of PTSD. If someone is sexually assaulted by someone they know, they will feel betrayed. They might not feel a moral injury. So, that could be there either way. Loss of meaning and purpose, trust issues, spiritual changes. So there really is a lot of overlap, and I think there's still a lot of research to do to understand what's common and what's distinct about moral injury. Again, for me, it really comes down to the spiritual existential piece that might be the most unique. And it also tells me that maybe when we're treating PTSD, maybe those are the things that people want to attend to that maybe we don't attend to enough in our treatments. And that's why this topic, at least in the veteran space, blew up so much, because it captured something that was meaningful to people that we weren't giving enough attention to in our treatments. But you know, when this first, when moral injury first started appearing in the literature for combat and veterans about 10 or more years ago, guilt and shame were not yet symptoms of PTSD, and they became symptoms because of some epidemiological work showing that they're actually extremely common among trauma survivors and among people with PTSD. So I think that's one difference that was there initially that actually isn't there anymore. So I started studying this topic. I became really interested. As I said, I started collecting data in my clinic. I then, you know, kind of developed a treatment protocol that I'll talk about a little bit later. I got some grant money to study the treatment protocol. As I've run and been part of various clinical trials, I've always tried to add a measure of guilt and shame related to the trauma to see, you know, what we could learn. So I'll give you a couple of examples. In this study from a trial where we compared prolonged exposure therapy and sertraline for the treatment of PTSD, we found that in the baseline sample, so that trauma-related guilt cognitions partially mediated that relationship between PTSD symptoms and functioning. So even when you control for PTSD symptoms, when people have more severe guilt, their functioning in relationships, in work, in education, in family is worse. In another study where we used that clinic data that I mentioned, we just interviewed all patients coming into the clinic who were willing to sign a consent form. And we found that if they had more guilt, their PTSD was more severe and their depression was more severe. We then actually started measuring shame as well. And shame, again, that more global attribution of I am bad, it seems to actually add a lot. So it was really, we found when we looked at both shame and guilt, shame actually predicted more aggression than guilt among veterans. And in a study where we did start looking at treatment, we found that as guilt got better, PTSD symptoms and depression symptoms got better. So they seem very interconnected. I'll just briefly say, we don't have good measures of moral injury outside of military samples, and it's something that I'm working on with a colleague right now. We're developing a measure that can be applied to any moral injury from any source. But in the meantime, I would say if measurement is important to you, and there are validated scales of trauma-related guilt and shame, and there's good scales of anger and grief and betrayal, and I'm happy to share those with you if you're interested. So let me turn now to intervention, and I'll first talk about, you know, we're in it right now, right? In some places like New York, maybe things are getting better and hopefully they'll stay that way. In other places in the country, it seems like maybe things are getting to a worse point. So we're definitely, as a country, we're in it. So let's talk a little bit, instead of, you know, sort of post-moral injury intervention, let's talk about how we can be supportive of each other and try to prevent it while we're still in it. You know, self-care is not easy for healthcare workers. And my understanding is that with your organization initially, you got a lot more volunteers who wanted to help other people than callers asking for help, right? So that's probably a good lived example right there. We want to help, and we're not, you know, but we're not in the same numbers of asking for help. So having said that, it's still, you know, if I think for more, when we are experiencing moral injury, getting support, not feeling like we have to make impossible choices by ourselves in isolation, but working with colleagues, bouncing things off colleagues, going to Joe and talking about it as an ethics issue. All those things can kind of give us the support to prevent this long-term moral injury. And then if there is moral distress, of course, talking with others and you know, getting support there from loved ones, maybe from colleagues who you feel would understand or who understand is really important. And these are certainly the kinds of things that you can be talking about with people who call in. It's the should thoughts that are most dangerous. So I love that Andrew brought that up in his example, that, you know, the person realized that they were having these should thoughts that were really keeping them distressed. So helping peers identify those and helping them find a way, you know, rather than I should have been able to save the day, I wish I could have helped this patient. I wish I had the tools to help this patient, you know, survive, but that's not where we are with this virus right now. and similarly focusing on what we can control. There are some self-help tools. I don't know if you've heard of COVID Coach. These are from National Center for PTSD, or these are all freely available in apps for either Apple or other phones. So the COVID Coach, there's a mindfulness coach for those with PTSD. There's a PTSD coach, and those are just nice self-help tools people can have right on their phones. And then in terms of how colleagues can support other colleagues who they see struggling and think, maybe there's some moral distress there, of course, reaching out. And reaching out isn't a one-time thing, right? Because sometimes someone will say no once and feel shut down, but checking in again, and, gently, but again, is fine. And, I think sometimes there's a few people feel a lot of pressure to say the right thing or help, and just reminding people that they can just listen, that, the most powerful thing we can do is just sit with someone and listen sometimes, and that's fine. That's what they need, and that's super helpful, and take the pressure off of them to feel like they need to have an answer or say the right thing. And, I think when people feel this kind of guilt and shame, and there's, I think, actually some social psychology research that shows this, they really zoom in on their role in what happened. And whatever their role was, when they feel this guilt and shame, it becomes much bigger. They lose perspective. So really just talking through the situation with someone, kind of helping them kind of remember what all the players, all the pieces at the time, might just help remind them of the actual situation, that maybe there were things they couldn't control, or maybe other options also would have led to a negative outcome, or maybe they really had no choice whatsoever. They were kind of just along for the ride, although now they're telling themselves they should have been able to change the outcome. But helping them, just ask some probing questions if they're willing to talk. And then, of course, now among peers, there might be a lot of shared experience. So maybe actually a colleague wants to talk, and maybe that's too triggering for the person you're helping. And it's okay to let them know that they can set limits. They can say, hey, I can tell you're really struggling. Let's figure out what a good resource is for you. But, for me, this is too much right now. That's okay to set those limits. If you, I know you guys probably have so many resources at your disposal with the work you're doing. If you want to take a look, we've had some leading experts on psychological recovery and skills for psychological recovery and PSA. We have a lot of materials on the National Center for PTSD website. If you just Google NCPTSD or National Center for PTSD and COVID, a page of resources for self-help, for healthcare professionals to help others and themselves, and for supervisors comes up. And if you have the time, just take a look and see if there's anything useful there for you. And then in terms of leaders, I think transparency as much as possible. Some things can't be shared, but to share the thinking and decisions. It's much easier to feel betrayed when you can, make your own guesses and just sort of vilify the decision makers. But the decision makers are often in impossible situations themselves. So I think the more information that can be shared, then it's harder to feel that betrayal. It's good for leaders to send messages that moral distress and pain can occur. It's good for leaders to set a culture of check-ins and debriefs and praise for impossible situations and normalization, and sometimes to say, wow, there was nothing more you could have done there. Remind employees that they're doing their best under difficult circumstances. Remind them that it's okay under these kinds of circumstances, that they won't always be at their best. And to send the message that it's okay to get help when needed. So these are some of the things that self-care peers and leaders can do in the moment that might mitigate some of those potential downstream negative effects of moral injury. So I'll spend the last part of the talk on intervention, and I'm gonna try to move through somewhat quickly because I really want to leave time for discussion and questions. But, I think there's some, as mental health professionals, there's the non-specifics that we all know are critical, like having an accepting, non-judgmental, empathic stance with any client, any patient. But I think it really kind of is even more critical in these kinds of cases, because remember that this person feels that they have done something unforgivable. You might be the first person they're telling what it was, which is hard enough. They might be watching for your reaction. Are you disgusted? Are you judging them? Are you overwhelmed and crying? Is this, you know, are they too much for you? That might be another thing they're looking for. They might back up if they feel like they're too much for you. So, you know, showing them that you're accepting, that you can handle it, that you continue to feel connection and empathy with them can be very powerful. And, you know, stay open and alert, because a lot of times what the distress is here isn't what it appears to be on the surface. It might be, you know, you might think it's one thing at first, but as you talk with the person, it becomes something much more nuanced. So really kind of don't say, okay, we've identified it too fast, you know, keep listening to see what else comes up. And the thing with morals and values is that we have our own and we bring them into the room too. And so, you know, I have worked with you know, mental health providers who inadvertently will judge the patient's action and will say, well, yeah, they did do something really wrong. And, you know, we haven't walked in that person's shoes. And so I think just really what are our own assumptions about perpetration and morals and values that we might be bringing in. And watch for that self-sabotage, you know, again, that ambivalence, that not showing up, that, you know, the quote unquote resistance, it really might actually be that someone just has a lot of pain and confusion about whether they even deserve to be better. And that's a therapeutic issue. If you identify that, you can talk about it with the person. But if you don't identify it, that person might drop out, or their behavior might be judged another way. I mentioned there's a lot of overlap with PTSD, and we have kind of mixed information as to whether evidence-based treatment for PTSD works to reduce moral injury. We actually saw recently, I just published, did I publish it? No, we have a study under review with that study where we compared prolonged exposure therapy and sertraline, and in fact, both reduce guilt. So both the therapy and the medication reduce guilt, so that's encouraging. And in some cases, we've seen kind of mixed findings. And I think part of the reason we see mixed findings, where sometimes it seems like our PTSD treatments help reduce, you know, these core features of moral injury, and sometimes we don't, is because we don't know what's necessarily happening in the room with the patient. We don't know if it could be the same treatment, but one provider might talk about the guilt and really help the patient figure that out, whereas another may not. So I think that's what we really need to say, is not just what is the treatment, but how is that treatment being used to address the guilt. And I think that'll help us figure this out. If this is something you're interested in learning more about, my colleague Carrie Rogers and I actually have a course on the National Center for PTSD website that can be completed for a free CME on addressing guilt and shame in PTSD treatment, specifically in prolonged exposure therapy and cognitive processing therapy. Oops, what did I do? We also, several of us are studying interventions that we've developed that all have some promising pilot work, but we have trials in progress. We don't yet have, you know, that large, even single randomized controlled trial showing whether the treatment is effective, much less multiple ones. You know, this is still kind of a field in its infancy, but there is more acceptance and commitment therapy applied to moral injury, which is being studied. Treatment, I hear some background noise. If you guys could mute if you're not, actually everyone just mute, that'd be great. Adaptive disclosure, impact of killing is really specifically for killing in combat. There's some spiritually oriented treatments that really go after the spiritual injury that can happen with moral injury. And then mine is called trauma-informed guilt reduction. We just finished a trial where we randomized about 150 veterans to receive this therapy or supportive therapy. We're still collecting follow-up data, so we're done treating everyone, but we're still waiting for some 3- and 6-month data. So hopefully in the next year, we'll get this published. And I'll tell you a little bit about what we've done. It's a 3-module intervention based on cognitive, behavioral, and acceptance-based principles It's really transdiagnostic for this kind of moral injury or guilt and shame from a very stressful or traumatic event. And it consists of psychoeducation and really appraising the guilt event, kind of a processing, and then a focus on values. So we start with this idea that a trauma or a stressor might occur, and some people feel no guilt from it, and that's fine. And those that do feel guilt, maybe they don't avoid that guilt, and then they can learn from it. And social psychology teaches us that guilt can be quite adaptive. If you do something you don't feel good about and you feel guilty about it, and you say, why do I feel guilty about this? You might actually say, well, I don't want to feel guilty like this. What's making me feel guilty? And change that behavior, and then you don't feel guilt anymore, and now you're doing something better. So guilt has served a purpose. But what we know with people who have a lot of distress after very stressful events or traumas, that often they avoid thinking about the event, thinking about reminders, and that avoiding coping, what we propose in this treatment is they still have that guilt, but they're not thinking about it. So, but they have that awful feeling of guilt, and so they actually take that as evidence that they did something really bad without actually looking at what happened. So then they feel more distress, and then they, feel more guilt, and it sort of creates this cycle. And then it could break out and create the sense of shame as well, of not just I did something bad, but I am bad. And we propose that it's this cycle that kind of feeds into this greater severity we see of alcohol use disorder, substance use, PTSD, depression, suicidal ideation, functioning. So that's what we try to break in the treatment. In the first module, we go over this model of non-adaptive guilt and shame that I just showed you. And we talk about, guilt, the relationship between guilt and shame and moral injury. And we start looking for the function of the guilt. And I'll tell you, and I think this is probably really important for your work as well, one thing we found is that this guilt and shame serves a function. So we would treat people with kind of the cognitive behavioral piece of it. They'd come away and they'd say, oh my gosh, you're right. I did the best I could, and I really couldn't have changed the outcome, and something bad was going to happen no matter what. And we'd think, wonderful, they're not going to feel guilt anymore. And then the next week they'd come back and they'd be right back in that guilt. And we'd say, how could this happen? What happened? And so then we realized that the guilt was serving some sort of function. And so we built into the therapy kind of watching from the very beginning, and then really explicitly discussing with the patient down the road, sort of what is the function of the guilt for you? And we started learning things like, well, if I didn't feel bad about this, I'd really be a bad person. Or what would stop me from doing it again? Or how would I honor the memory of all the people who died if I didn't feel bad? And basically there was a function there that needed to be filled, and they were suffering to fill that function. And so one of the things we do in the intervention is we help them find other ways to fulfill that function that are more positive than suffering through guilt and shame. So in the second part of the treatment, we really work to figure out what is that should or shouldn't have. So maybe it's not that I wish I could have done more for all those COVID patients, but it's really, how could I not have felt anything when I was on the unit? It might be sort of kind of come down to a more nuanced point than what it seems at first. So we work to identify what they really should or shouldn't have done that's causing the guilt and shame. And then we go through a few exercises with them to help them kind of, again, just get this broader perspective. So foreseeability and preventability is really around kind of hindsight bias. People are telling themselves they knew something was going to happen, they should have been able to do more, and we kind of really break that down and think, what could they have done at the time? What did they know? The justification is often they're telling themselves there were choices and they picked the wrong choice. If they had picked a different choice, something would have happened that was better. And so we actually have them write down what they did and what the pros and cons were of that situation, of what they did. And then we have them write what are really realistic other things they could have done, options that were really available to them at the time, not ones that they couldn't have done or they didn't think of till later, but what was really available to them. And we have them write the pros and cons of that. So this is an example of someone I worked with a very, very long time ago that's adapted, but it was someone who had served in the military and had to meet with a family, and then the family actually got killed by insurgents, and then they had to clean out the bodies. And during that, his unit, they were making a lot of crash jokes, and he kind of participated in that. And so there were a lot of parts where he could have had the moral injury, but what we come down to the should or shouldn't was I lost my humanity when I participated in that. The family was nice to us, and I did a horrible thing. And so we talked about the pros and cons. And so he feels like, you know, he by sort of being part of the unit, he got the job done. He pushed his emotions aside. He coped with the situation. He did his share of the work. They needed to get in and out. It was a dangerous situation. And by sort of pushing his, you know, normal, you know, sort of what he called his human desires to sort of mourn, and he was able to do that. But the cons was he disrespected the family. He feels like he lost his humanity. So had he mourned, it would have been the right thing to do, the human thing to do. That was the pro, but the cons were that he would have stood out and not done his job and put others in danger. And the third thing would have been to actually say, stop everyone, this is not okay. Like, we can't, you know, stop doing this. And so again, that would have felt right, like the right thing to do. But he would have alienated himself. His staff sergeant was participating, so he would have been insubordinate potentially. He was already kind of didn't fit in and was having a very hard time with his unit, so he would have been kind of further bullied and potentially in danger. So I think this didn't make him feel great about his choice, but this showed him that it minimized the danger for his unit, it optimized his own ability to do his job and his survive. And he had a better understanding of why he made the choices he did. The next part is we do a responsibility analysis, because again, when someone feels guilt, they're pretty sure they're really pretty uniquely responsible for what happened, but we have them sort of take in the broader context and talk about other things. So in this situation, they were at war, they were following orders, insubordination would have, you know, had big consequences for him. I found that I asked, and it turned out they'd slept about 3 hours in about 3 days. So of course he was having these sort of weird, you know, affects, you know, laughing inappropriately, things like that, that he felt this real sense of derealization during the whole thing. So it didn't even feel like real bodies or real people, you know, in his survival instinct. So we rated all of these as he went along, and initially he said he was 90% responsible, and then I just said, well, how much is this? How much is this? And I didn't try to wrestle him away from his guilt or his sense of responsibility, but I just showed him this, saying, okay, so you're responsible, but all these other things are too. So I sort of helped him right size it. So in the last part of the treatment, after we've sort of gone through, that's just a couple of examples, we go through more exercises to kind of help people gain this perspective. And then we kind of come back to this conversation around what would it mean to feel less guilty going forward? And that helps us get to what were those values that were violated. And that helps us turn to the last part of the treatment, which is, well, what can you do to honor those values? Let's look at your everyday life, how you spend your time, where are you expressing these values, how can you express them more? We literally have like a calendar, and we do some exercises to identify values in different areas, not just the ones that were violated, but others that are important to them. And we really try to help them create a life that's more full of expressing their value in positive ways, because we can't ever say to them, it wasn't your fault, you did the best you could. They won't hear that. They'll just hear that we won't understand. So we don't try to wrestle their guilt away from them, but we try to fill their life in a meaningful way, so that hopefully they don't need that guilt and shame anymore to express their values. And over time, they kind of gradually, naturally move away from it. So I mentioned that we're just finishing up a grant. So I'll just say in closing, that, you know, a lot of what I've said today obviously is coming from research and work with veterans, and, you know, that we're just really at the beginning of this road of applying moral injury to healthcare, to so many other important areas. I think what we need to do is, right now we're at extrapolation, but we need to really understand, to listen, to do research, to learn. We need better measurement. To study this, we need to understand how common it is and the short and long-term impacts. And we need to know how to help people who've experienced this move forward in a meaningful and positive way. So that's the work ahead of us. So I will stop there and would love to have some discussion. And I think actually first we're gonna have Joe comment, right?
Right. So thank you very much. And, you know, just reflecting on the fact that the Cornell Grand Rounds that we had was about 43 days ago, which is pretty much what a quarantine is. It's quarantina, or 40 days, which is what happened during the bubonic plague in the Middle Ages. And a lot's happened in those 40 days or so. New York is now getting back to some semblance of normal. And I want to thank Smita for allowing this session to be therapeutic for me, because as I watch around the country, and I have friends in the Southwest, and we have an affiliated hospital in Houston, and they're getting overwhelmed in the way that we got overwhelmed. And I'm just thinking of the tragedy of it all. And for me, that is constituting a stress, a distress. Like why couldn't we learn from the experience in New York? Why did we turn this into an ideological question about whether one wore a face mask or not? And there's that sense of powerlessness, the sense that power is greater than science and reason, have led to this impending catastrophe that is actually going to probably be worse than New York, because it's so widespread. It's not just happening in one city; it's happening in an entire region of the country. So I have a little trauma, and I appreciate all these psychiatrists and psychologists here to help me. Thank you very much. But what I want to do this evening, and I'll be brief given the hour, is talk a little bit about what we've learned. And I think there's a parallel universe to what Sonya described from ethical analysis, which is not psychological or psychiatric, but a different way of looking at the same experience. And we were in charge of the ethics response at our hospital, and we're just finishing a paper now looking at it systematically. And in the 6 weeks that we studied, we did over 100 ethics consults, which annualized was a 300% increase from what we normally do. Over a year, we do 350 to 400 consults. In this 6-week period, we basically did 100 consults. Plus, we had 2,500 other interventions, mediating between services, talking with leadership. We were incredibly busy. And what happened during the thing that I think is relevant to what Sonya was talking about is that the ethicist became the priest confessor to talk with clinicians who felt they had done something wrong. They felt they didn't do their best job. As Sonya described, clinicians were taken out of their comfort zone. They were redeployed. We all have a bit of OCD. It's a healthy aspect of professionalism. We're very proud of the excellent care we provide. And here we were taken out of our comfort zone, and psychiatrists were running medical units, and regular internists were running pop-up ICUs. And nobody did the job that they wanted to do. And then when they went home at night, they were lauded by 7 p.m. applause, because everybody else thought they were heroes. The people had to believe that their doctors were heroes, but none of the doctors felt they were heroes, because they never felt they did enough. And I want to explore from, in ethics speak, why none of us felt what we did was heroic. It was always someone else did more than I did. When I talked to my father about World War II, he was a combat medic. He said, yeah, we saw combat, but those guys were Rangers. They did more. But even the Rangers felt they didn't do enough. And I think our clinical colleagues did not feel they did enough, because it was a breach of ethical proportionality. Because they had to, what do heroes do? They assume a disproportionate burden of a problem. They're kind of like Atlas holding up the entire world. Everybody else has abdicated. There wasn't enough PPE. There wasn't enough support, and they have to take on all the burdens, and the burdens weren't equitably shared with their colleagues, with their supervisors, with society, with preparation, and they had to bear the entire burden. And I think that this disproportionality leads to burnout and frustration. And ultimately, you can't run a pandemic expecting heroism. You just have to hope that you get professionalism. And that gets me to my second point. what does it mean to be a professional? It means to be an ethical physician. And I think that one of the things that I think is very helpful here is the role of ethical discernment done in a collectivity where clinicians can talk to other clinicians about the choices they made. It wasn't they had an ideal set of choices. They could either do the best they can with the Institute of Medicine called a sufficient standard of care or under crisis standards of care, or they could provide no care at all. And I think one way to help people understand this and understand what Sonya was talking about, what kind of secondary gain was gleaned from feeling guilty, to understand through deeper ethical analysis and discussion of the issues that were at hand. And I think that can be a kind of an intellectual way to accomplish some of the emotional work that can happen in parallel. A final quick point I want to make, given the late hour, is to caution us not to overdraw an analogy to the military experience and PTSD. We all know that what PTSD often exacerbates itself when service members are separated from their units, and the cohesiveness and the glue that allows people who've gone through a shared experience that's taken away, and which held them together begins to disintegrate, and they begin to deteriorate when they go back into civilian life. For better or worse, those of us who are clinicians working in these hospitals, we're stuck with each other. We remain in the house of healing, and I think that we retain the cohesiveness of the unit. And I think by understanding this collective trauma as a collective, we'll be able to perhaps find a way back to resilience. And one last point, and I have a little question about this word, this notion of moral injury, because from an ethicist point of view, morality is about right and wrong, whereas ethics is about competing goods, making choices between competing goods. And so I think it's helpful to understand and help the clinicians go through this discernment, ethical discernment, to understand that what they did was not right or wrong, but it was the best they can do under extremely dire and tragic circumstances. And I think that if we engage clinicians this way and have group discussions, because most people, as Sonya said, will not have PTSD. Most people who go to war do not have PTSD, and most of our clinical colleagues will not have PTSD. We shouldn't pathologize it. We should understand it as a collective trauma. For the vast majority of people, they can heal each other by returning to their groups, going back to their clinical spaces, talking about their experiences, engaging in ethical discernment, and perhaps finding their way back to some sense of normalcy. We'll all have been changed forever by this experience. That's not something we can undo, but we can help people reframe it and understand it in a positive and constructive way. So I'll stop there and turn it back to, I guess, Smita or Carol. Thank you.
Thank you. Is it all right to invite questions now?